Bismillah ar-Rahman ar-Rahim. As all of you know that we have been discussing UTI for the last few weeks. I will be discussing today acute pyelonephritis. We will be go a little bit about talking about renal infections. Then we will go in details about acute pyelonephritis, etiology, presentation, and diagnosis and management. Renal infection is usually associated with renal pelvic or and renal pelvocalycal system inflammation. It comprises of heterogeneous group of conditions include acute pyelonephritis, chronic pyelonephritis, renal tuberculosis, emphysematous pyelonephritis, fungal pyelonephritis, and xanthogranulomatous pyelonephritis. Chronic pyelonephritis is characterized by renal inflammation and scarring induced by recurrent and persistent renal infection. Caused by recurrent and persistent renal infection or vesico-urethral reflux and other causes of acute or chronic urinary tract obstruction. Diagnosis is usually made in the basis of imaging studies such as ultrasound, CT scan, and sometimes renal scan. Renal tuberculosis accounts for 15 to 20% of extrapulmonary tuberculosis. Tuberculosis can involve both the renal parenchymal and the collecting system and renal pelvis. Diagnosis can be obtained by culturing multiple first morning void urine samples or by histological of imaging guided biopsy or by the surgical specimen. Emphysematous pyelonephritis is a urological emergency characterized by acute necrotizing parenchymal and perirenal infection caused by gas-forming uropathogens. Most common in diabetic patient. The usual clinical presentation is severe acute pyelonephritis. Almost all patients will be presented with classical trials of fever, vomiting, and pain, flank pain. Emphysematous pyelonephritis occurs mostly in females. Almost 90% of the patients have uncontrolled diabetes. It also can occur in immunocompromised patients and in patients with urolithiasis or neoplasms. The most causative organism of emphysematous pyelonephritis is E. coli. And also Klebsiella pneumonia and Proteus mirabilis can cause emphysematous pyelonephritis. This is a plain X-ray of a patient with bilateral emphysematous pyelonephritis showing motile gas within the renal fossa. There is also a linear gas shadows along the paraspinal region representing retrovenal air. Ultrasound demonstrates strong focal echoes suggesting the presence of intraparenchymal gas. CT is the best diagnostic modality for emphysematous pyelonephritis. It shows enlarged distracted renal parenchyma or linear streaks of gas fluid collection within the gas fluid levels and focal necrotic areas plus minus an abscess. This is a CT with contrast of a patient with right emphysematous pyelonephritis showing enlarged kidney with distracted parenchymal tissue with linear gas shadows. Acute pyelonephritis is an inflammation of the renal parenchyma and the lining renal pelvis, commonly secondary to bacterial invasion. And the annual rate is 15 to 17 cases per 10,000 in females and 3 to 4 cases per 10,000 in males. Almost 20 to 30% of pregnant women with untreated asymptomatic bacteria will be developing acute pyelonephritis. Acute pyelonephritis results from bacterial invasion of the renal parenchyma. The bacteria reach the kidney either by ascending infection from the lower urinary tract or by hematogenesis spread. E. coli usually has a special virulence factor such as B. fambry or fambry type 1 and mannose resistance antigens plus some toxins. So they can withstand the host defense system. So they cause more than 80% of the cases of acute pyelonephritis. Patient bearing blood B group phenotype has a special susceptibility of getting recurrent acute pyelonephritis secondary to E. coli. More resistant species of such as Protease, Klebsiella, Pseudomonas, and Serratia enterobacter can also be suspected in patients with recurrent UTI or hospitalized patients and patient with indwelling catheters, and in patient who has underwent urinary tract instrumentation recently. Acute pyelonephritis, it can be complicated on the non-complicated. Non-complicated pyelonephritis usually occurs in healthy young women. The bacterial invasion and renal damage is limited to the bilvo-calycal and medullary regions. However, complicated pyelonephritis usually occurs in patients with structural abnormalities such as obstruction, enlarged prostate, reflux, and metabolic and hormonal abnormalities like diabetic patient, and impaired host response in immunodeficiency patients, and unusual pathogens such as yeast. In complicated pyelonephritis, all the regions of the kidney may be affected.
Faraj?
Yes, sir.
Complicated also pregnant ladies, cancer patient, polycystic kidney, and also they are included in complicated patients.
Yes, sir.
With abnormal renal functions.
Yes, CRF patient. Yes, sir. E. coli can cause up to 95% of uncomplicated UTI and up to 54% for complicated UTI. Proteus mirabilis up to 10% of complicated UTI. Klebsiella can cause up to 17% of complicated UTI. Pseudomonas aeruginosa can cause up to 19% of the complicated UTI. Staphylococcus aureus also can cause up to 23% of the causes of complicated urinary tract infection. Patient with acute pyelonephritis usually present with flank pain, subarachnoid pain and discomfort, fever, high grade associated with rigors and chills, malaise, weakness, anorexia, nausea, vomiting. About 40% of the female patient may present with gross hematuria. Children, specifically neonates and infants, we will be presenting with failure to thrive, feeding difficulty, fever, vomiting. Elderly patient may be presenting with the classical symptoms of acute pyelonephritis, or they may experience fever and mental status changes, or decompensation in another organ system, and generalized weakness and deterioration of health. On physical examination, patient usually looks uncomfortable and looks ill, and the toxic log of the patient, if the patient is on sepsis or dehydrated, usually there is a raised body temperature, blood pressure usually within normal range unless the patient is not in sepsis. Flank tenderness and suprapubic tenderness usually there. Acute pyelonephritis is suggested usually by history and physical examination and supported by urine analysis results. Urine analysis results usually shows biuria, leukocytes caused in the urinary sediments. It suggests of acute pyelonephritis. There is a bacterial rows and chains of cocci, numerous RBC. Proteinuria can be also be there. Urinary neutrophil gelatinase associated lipoclean is sensitive biomarkers in the diagnosis of acute pyelonephritis in children. A study shows that up to 95% of children with acute pyelonephritis will be having a raised urinary neutrophil gelatinase associated lipoclean. So it is highly sensitive biomarkers for diagnosis of acute pyelonephritis in children. Urine culture is usually positive. There is usually raised TLC counts, specifically neutrophils, increased erythrocyte sedimentation rate, elevated C-reactive proteins, elevated creatinine. Usually sometimes acute pyelonephritis. In blood test, there is a raised TLC counts, especially neutrophils, increased SR, and elevated C-reactive proteins, elevated creatinine. One of the complications of acute pyelonephritis is acute kidney injury. So some patient may be presented with elevated serum creatinine. So sometimes blood culture may be positive. Imaging evaluation of the upper urinary tracts with ultrasound should be performed to rule out urinary tract obstruction and renal stones in patient with history of urolithiasis, renal function disturbances, or high urine pH. Consider further imaging in admitted patient if the fever is persists for longer than 48 hours, positive blood culture, sudden worsening of the patient condition, toxicity persisting for longer than 72 hours, and uncomplicated UTI. Ultrasound is insensitive to the diagnosis of acute pyelonephritis. Most patients having a normal scan or abnormal is only identified in up to 25% of the cases. However, ultrasound is useful in assessing the local complication of acute pyelonephritis such as hydronephrosis, renal abscess formation, renal infection, perinephric collection, and those guiding in management. Most ultrasound finding in acute pyelonephritis is presence of echoes in the pelvocalycal system and reduced blood flow in the cortical, reduced blood flow in the cortex, and gas bubbles in case of emphysematous pyelonephritis, abnormal echogenicity of the renal parenchyma, focal or segmental hypo or hyperechoic regions. This is an ultrasound of a patient with right pyelonephritis. There is a hyperechoic focus in the inferior wall of the hyperechoic focus in the lower wall of the right kidney. And the other picture shows mild hydronephrosis in the same kidney. This is another ultrasound of another patient of the right acute pyelonephritis, shows which chipped hyperechoic focus on the upper wall of the right kidney. On color Doppler ultrasound, there is a decreased blood flow in that area. Ultrasound bar Doppler also shows diminished blood flow in the affected area in the upper wall of the right kidney. CT scan is most sensitive modality for the renal tract. It is able to assess the renal calculi, gas, perfusion defects, and collection and obstruction. Non-contrast CT kidney usually sometimes appears normal in non-contrast CT, and sometimes the affected part of the renal kidney may appear swollen with low attenuation. Renal calculi and gas within the colic system may be seen. Post-contrast CT, there is a focal wedge-like region will appear swollen and shows reduced enhancement compared to the normal portion of the kidney. The periphery of the cardiac is also affected. That is called REM signs. The excretory phase striated nephrogram may be also visible. If it happens that you take a big 3 to 6 hours films, you will see persistent enhancement of the affected regions. That may be an evidence of a slow flow of contrast through the involved tubules. This is a non-contrast CT of a patient with right pyelonephritis. There is a focal hyperattenuation area in the upper wall of the right kidney that shows no uptake of contrast in the initial nephrogram phase. And this is another CT with contrast of a patient with the right acute pyelonephritis, showing a spoke wheel appearance of the renal cortex. This is ultrasound and CT of the same patient. So ultrasound shows just only slightly enlarged kidney that hide the severity of the disease. So and the CT shows a small local attenuation foci, that is indication of multiple micro abscess, that usually this patient will need a nephrectomy in future. MRI usually reserved for patients who are pregnant, and finding are those mirror to that of the CT scan. This is an MRI of a patient with right acute pyelonephritis. The infected upper bowl remains bright due to the compromised perfusion, while the mid and lower bowl showed a signal drop off due to the normal perfusion and uptake. The MSA demonstrates similar reduction in the renal perfusion and function, which one or more wedge-like defects in the outline of the kidney. This is a DMSA scan of a patient with right pyelonephritis showing a phytopenic peripheral defect in the upper lateral margin of the right kidney. Management of acute pyelonephritis. A patient, usually young female patient that presented with uncomplicated pyelonephritis, can be managed as an outpatient. She should be otherwise healthy, and she shouldn't be a pregnant lady. And initial management should be started in the AR in the form of analgesics, antipyretics, oral hydration, and 1 dose of IV antibiotic. Admit all the patient with complicated UTI, inability to maintain adequate oral hydration, and or there is evidence of vasomotor instability, unresolving or unrelenting fever despite of antibiotic therapy, severe pain and dehydration that can't be corrected within the AR immediately, and the inpatient who have an acute home or resources such as homeless patient and adolescents, and the drug abuse patients. Emergency surgery may be indicated in patient with fever and positive blood culture that persists more than 48 hours, and in patient with deterioration of conditions, and in patient who appears toxic for longer than 72 hours. Those patients usually have abscess, emphysematous pyelonephritis, or obstructed system. Antibiotic selection. Antibiotic typically should start empirically. The initial selection should be guided by the local antibiotic resistance patterns. Culture results of the specimen collected before the initiation of therapy should be checked in 48 hours to determine the efficacy of the empirical therapy that has been started. And this is the recommended regime of a patient that will be managed as an outdoor. Ciprofloxacin can be given orally for 7 days, levofloxacin, Ceftriaxone DS for 14 days, cefodoxium for 10 days, ceftriaxone for 10 days. Admitted patient will be needed supportive care like antiemetic, antipyretic, and monitoring of urine and blood culture results, monitor comorbid condition for deterioration, IV hydration until the patient is able to maintain oral hydration, continue IV antibiotic until significant improvement in the condition. It can be converted to oral antibiotic once patient is asymptomatic with tailored according to the urine and blood culture results. This is the recommended IV antibiotic for admitted patients. The first line is ciprofloxacin and levofloxacin, cefodoxium, ceftriaxone. Second line, cevispium and tazocine, gentamicin, amikacin. Third line is usually reserved for those patients who their initial culture shows multiple drug resistance organisms. This include imipenem, meropenem, cefodoxidium, and meropenem. So if the patient is presented to the ER with the symptoms and sign of acute pyelonephritis, fever, flank pain, and raised TLC, if patient is not in sepsis and there is no nausea or vomiting, so send urine culture, do ultrasound to rule any obstruction. And if there is no obstruction, you can start him an oral antibiotic and send him home. Ask him to follow up after 72 hours. If there is improvement in the symptoms, so continue antibiotic for 10 days. Send urine culture in the 4th and 10 days. And if there is a need of urological evaluation, you may do it in the 10th day. After three days, if there is no improvement in the symptoms, you have to admit the patient, review culture reports. You may need further imaging. So start IV antibiotic. If there is any sort of obstruction or there is any abscess, you should drain that. If the patient presented with the symptoms of acute pyelonephritis and the patient is on sepsis, patient should be admitted and radiological evaluation should be done. Blood and urine culture should be sent. IV antibiotics should be started in the form of ampicillin plus gentamicin. Fluoroquinolones also can be given, or third generation of cephalosporin. If patient is not improving, you should consider further imaging and drainage of an obstruction or an abscess if there is any. Pregnant lady usually with acute pyelonephritis, the most beta-lactam antibiotic are the treatment of choice. IV antibiotic should be administered until the patient is symptoms free. Once the patient is febrile for at least 48 hours, they can be switched to oral antibiotic and discharged to complete 10 to 14 days of treatment. This is the recommended regimes for pregnant lady. If the patient have a mild to moderate pyelonephritis, so ceftriaxone IV, cefipium can be also given, cefotaxime, ceftazidime, ampicillin. If patient is immunocompromised like diabetic patient and she is pregnant, so it is better to start her in tazocine or ampicillin, sulbactam 1.5 gram IV. This is a summary of management of a patient with emphysematous pyelonephritis. If the patient is diabetic and admitted with fever and UTI, so IV fluid and antibiotics should be started. Urine and blood culture should be sent. If ultrasound picture shows a no obstruction, or there is no gas, so continue IV antibiotic. If there is obstruction, so you have to relieve the obstruction. If ultrasound shows focal gas in the renal parenchyma, so do CT scan. If the gas in the collective system, considering drainage and antibiotic. If there is no response, so patient might need nephrectomy. If there is a gas in the renal parenchyma, and most likely this patient will need a nephrectomy. If there is a gas and fluid in the perinephric tissue and renal function is compromised, consider antibiotic and drainage. If there is no response, so most likely this patient will need a nephrectomy. Take-home message: patient history and physical examination supported by urine analysis play a fundamental role in the diagnosis of acute pyelonephritis. Urine culture and sensitivity testing should always be performed. Antibiotic therapy is essential in the treatment of acute pyelonephritis and prevents the progression of the infection. Patient presenting with complicated pyelonephritis should be managed as an inpatient and treated empirically with broad-spectrum IV antibiotic. Thank you.